So you can see how excited and why I'm so excited to work with Steve. He's great. A couple things there, Steve. De rigueur, that's kind of going to come into my vocabulary. 2, we're Star Wars people, not Star Trek people. But 3, we should talk more. I think the main point is we should talk more because there are newer drugs that can target those macrophages. And so that's what Dr. Mehmi and I will start talking about on Monday when we're in clinic together. But I'd like to bring up Dr. Mehmi to do another staple talk for Dr. Sapna. It's going to have a lot of doctors. So a long time ago, I told Sapna that she should come and work with me, or I'd like to work with her more, but I have the next best thing. Dr. Mehmi will come and talk to us about where he's taking the ocular melanoma program here and what's happening everywhere. Contrary to the belief of this meeting, it doesn't just happen in MD Anderson or Mass General, but there's a lot of great work going on, and Dr. Mehmi will let us know about those.
Next best thing. That's a lot to live up to. So I'm going to try and summarize. I know this is the last talk and everybody's a little tired. So trying to make it short, but still trying to cover some of the data that's been generated in uveal melanoma. And we'll talk about that. So objectives are, I covered a little bit of this on last year's symposium, background, prognostic markers, staging, and what that allows us to do in terms of following the patients. Where are we with metastatic disease management, and what are some of the future therapies that are on the horizon? So little picture of what exactly uveal melanoma. A lot of the time when I speak to patients that are newly diagnosed, they never even knew that this disease actually existed. It's like, oh, melanoma can happen in the eye. Oh, does it go from the skin to that place, or is it a diagnosis on its own? And it's this is one of the common adult ocular malignancies. It can happen in a number of places, as you can see. Okay, so a little bit of background. It's most common primary ocular melanoma, or a malignancy of the eye in the adults, about 5% of all melanomas. It's not that common, as you can see from the incident rate. There are some risk factors, but they're not the same as for cutaneous melanoma. And unfortunate situation is a lot of the patients go on to develop metastatic disease. And historically speaking, it's been difficult to control. The therapeutic regimens that we've had in the past weren't very adequate in a sense, and also they weren't very tolerable either. So we push along and trying to find therapies that are more effective and better tolerated. So this is just a slide on how we stage melanoma, and what that helps us with is how to approach the surveillance of these patients. You know, if are they at high risk of recurrences or not, and that helps us along with that. But to sort of make that picture a little bit better, a little more complete, we do get sort of gene expression, certain DNA markers that are present in these melanomas. And based on those markers, we divide or stratify these melanomas into low risk versus high risk, class 1, class 2. And that allows us, again, to perhaps design clinical trials for post-operative therapy or post-primary therapy of ocular melanoma that will address the highest risk patient population, whereas the low-risk patient population could be followed along. And as you can tell, even on a longer-term follow-up, that these classifications stand test of time. And furthermore, you can add other pieces of information, for example, PRAME, to this gene classification that allows us to further risk stratify these patients and potentially see if there are adjuvant options that could be explored in a clinical trial setting. And this PRAME thing will be important a little bit later. Dr. Hamid sort of, talked about it in a different setting, and I believe Dr. Sullivan had also hinted towards that. So this is a quick slide on adjuvant therapy for melanoma. Unfortunately, a number of trials have happened. Most have been small, but none really shown any benefit. So at the moment, outside a clinical trial, there is no approved adjuvant therapy for uveal melanoma. This is bring to real life sort of statistics of uveal melanoma, how scary of a disease it is, and what the outcome for these patients with metastatic disease can be, and highlights how much work that needs to be done. So in the metastatic setting, most of the time, these patients will be exposed to a number of different approaches for their disease control. Let it be a liver-directed therapy of various types, hepatic artery embolization with different agents, for example, immunoembolization. A lot of it's done at Thomas Jefferson with Dr. Soto's lab and clinic. Chemoembolization, radioembolization, Y90 treatment is one of those. Hepatic artery infusion, a recently published article from Europe, a group in German group, I believe, showed benefit of percutaneous infusion. Also, Delcath is another system that goes after the same approach to improve liver sort of recurrences. This is the Delcath clinical trial, percutaneous hepatic perfusion with melphalan for patients with ocular melanoma that's metastatic to the liver. And it showed a very good control of disease in the liver and also overall survival advantage. I'm not sure why this is not FDA approved yet, but the data has been out there for a while now. And so the next thing is there anything else within the uveal melanoma cells, a mistake in the pathway that allows it to grow, progress? Is there something we can target? So there are a number of mistakes that have been identified in uveal melanoma, but so far we haven't found a silver bullet for it. For example, in chronic myelogenous leukemia, one of the drugs that was developed, Gleevec, essentially has changed the nature of that disease. And there's a strong effort in uveal melanoma to find that silver bullet for that one mistake that we could take advantage of. And so far, we haven't seen significant improvement with these number of different targeted therapy, for example, with trametinib or sorafenib or selumetinib. We haven't really seen a lot of benefit, but times are changing. And so this is a study of IDE 196 in patients with solid tumors harboring GNAQ11 mutation or PRKC fusions. This is trial by IDEA, pharmaceutical company, and their press release indicated that when they treated metastatic uveal melanoma patients with darvosertib, which is a PKC protein kinase C inhibitor, along with crizotinib, which is approved for ALK or ROS gene rearrangement in metastatic non-small cell lung cancer. When they combine these two drugs in various settings, for example, they've treated patients who have never been treated for metastatic uveal melanoma and patients who've experienced other treatments. And once they've given these two drugs in combination with that, they've seen a reasonable response. For example, if any of the patients they've seen prior therapy, they looked at 35 patients and 11 of them had overall response. Whereas if the patients hadn't had any therapies in the past, the response rate is about 50%. My only caveat to this is these are numbers that are very small. We need a larger population to sort of establish this experience, and the trials are actually in an expansion phase and ongoing, and we hope to see the data soon. I think theme of my talk, even before when I was talking about adjuvant, neoadjuvant therapy in melanoma, was not only to have an effective therapy, is to have a therapy that's tolerable. What's the point of giving a therapy if it's going to make you sick and lay in bed at home or not be able to enjoy the life that you want to live? So going along the same theme, the toxicity profile is actually fairly well tolerated. High-grade events are small, and grade 1-2 events are essentially and most of them were GI focused. So we talked about immunotherapy in a number of different contexts and what is the role of immunotherapy in uveal melanoma. And this slide essentially shows you that uveal melanoma most commonly tend to be cold tumor. They're not very inflamed tumors. Because of that, the response to immunotherapy has been as good as what's been in cutaneous melanomas. But there are few percent of the patients that will benefit from these therapies, and that's the trial that led by Dr. Patel yet again, and showed about 18% response rate in some of these metastatic uveal melanoma, and we didn't see any new toxicity signals when these patients were treated. So it's a reasonable option for some of these patients. And the same trial was actually taken under back in Spain as well, showing a very similar. So essentially, both of these trials are stating that there is about 18 to 20% of the patients of uveal melanoma that tends to be immune therapy resistant, but still could be captured and with a reasonable control. And this is one of the newest drugs that got approved about a year or two ago. And that's the class that Dr. Hamid actually elaborated on, the IMTACs. And this is the CD, it's a bispecific antibody. I call them I think a lot of the people call them T-cell engagers. And one end, again, to review, is binds to the T cells. The other end binds to the tumor itself at the GP100 site. The only catch here is that you have to have a particular human leukocyte antigen, HLA-A*02:01. And if you don't have that, you're not a candidate for this therapy. I believe the Immunocore data shows that there are about 40% of the patients who are HLA positive for this particular drug. So they are a very good candidate, which means there are 60% of metastatic uveal melanoma patients that aren't candidate for that therapy, that requires additional work from all of us. So this is the trial that was published in New England Journal of Medicine in 2021. These are some of the, on the upper left corner are the basic characteristics of these patients. And in the middle, typed up are some of the inclusion, exclusion, and some of the other details of this trial, showing overall survival benefit on the bottom left, and overall well-tolerated therapy. Most of the adverse events that happen, they happen within the first few weeks of this drug being given. Most serious thing that we worry about while you're on, when somebody's on this drug is what's called a cytokine release syndrome, which is essentially a chemical storm that the chemicals come from the immune system and all these inflammatory markers that are circulating in the blood and impacting your respiration, your blood pressure, your heart rates, and etc., your volume status, and sometimes liver function and such. But again, something that we monitor, and we monitor within the hospital setting, but at the same time, these are well-studied phenomena and relatively easy to control issues. The next T-cell engager is Dr. Hamid's gone over it. This is a slide you're seeing about fourth time today. This is Dr. Hamid already went over the detail of this phase 1 study where it looked at multiple different tumor types that are PRAME positive, PRAME positive, and again, also HLA-A*02:01 positive, and multiple different tumor types. And I want your attention on the far left upper top, the blue lines that are falling down, and the waterfall plot showing a very good response, and these responses are durable, and overall therapy is well tolerated. We have few patients on this particular trial benefiting from this. And last but not the least, Dr. Hamid also went over the TIL therapy, and there is some role of TIL therapy in metastatic uveal melanoma. Unfortunately, the current data shows that it's not as effective in uveal melanoma as it has been proven to in cutaneous melanoma. Again, potentially an option, perhaps newer engineered adoptive T-cell therapy will be better options. One of the trials that I wanted to highlight was treatment fields. So essentially what this trial is doing is combining two different modalities of therapy. So tumor treatment fields is a concept of generating electrical fields around the tumor to allow control of it. And the basic concept is when the cell is dividing, the chromosomes are moving on these charged strands called microtubules. Along with that, there are charged proteins, molecules stabilizing all that apparatus. When you focus electrical fields on that, it disrupts that array. And that disruption leads to cell death. So our thought here is that when we apply this particular tumor treatment fields along with immunotherapy, we'll have a better response. As a matter of fact, this is a trial in melanoma, but a trial in mesothelium is already taking place. A trial in GBM, glioblastoma multiforme, has been taking place. Matter of fact, it's a approved therapy in GBM in second-line setting, I believe. So we hope to accrue patients. I think we're treating our first patient on this study next week. Excited to be part of this. I'm going to end it here, and we'll move on to the question and answer session, I believe.